Hello, good evening.
Evening.
Hello, good evening, Jitu sir.
Good evening, Vijay sir. Hi, Amol.
Good evening.
Hi.
Hello, Vijay.
Hi.
Good evening.
How are you?
Fine, fine.
All good.
All are in the OPD, no?
I am sitting in the place of Dr. Amol.
Excellent.
I've absconded from there. No, I have come home.
You can see the photograph also behind that painting.
No, I'm just leaving for home. In another 5 minutes, you'll see a change in my background.
I think we're already live streaming. It started.
Yeah, okay.
Hello, Vikram. Good evening.
Good evening, sir.
Hello, hello. ओपडी त्रस्त वाटतंय एकदम.
We'll start on time, huh?
Yes, sir. 1 minute to go.
Vikram, make a YouTube live.
So we are live
now, huh?
Already live, sir.
पाच मिनिट. Yeah, hello. Shall I start, sir?
Yes.
Good evening, friends. Welcome to the new start of our again midweek Bonjana. That is what we call as the Wednesday midweek academic box office. And for this session today, we got the none other than our master blaster, that is Vijay sir, to guide us about the newer arrival. I thought it's something like new iPhone is arriving or new like दुकान में जैसे रहते new arrivals. Something is new coming, and definitely we are looking forward to you because every time you give something newest knowledge, even other GAN also. So for this session, I welcome you and I request our president, Dr. Jitendra Gawade, to say few words.
Thank you, Satish. Good evening, all. On behalf of MGM IHS and IIP Navi Mumbai, I welcome you all.
छापेमारी कर रही है झारखंड बिहार समेत 25 ठिकानों पर छापेमारी हुई जिसमें कई बड़े नाम.
किरण मैम थोड़ा म्यूट कर ले. All of you, please mute yourself. Sir, please.
Yeah, sorry for interruption. So friends, nowadays we all are busy in our monsoon maladies, dealing with various patient coming with febrile illnesses, and somewhere we are having a lot of OPD, and we are having a fear also that we should not miss something which is not related to the infection, or it is mimicking like an infection. So I requested Vijay Vishwanath to have some delicious food dinner with some dessert tonight, so that we can take those points in our daily OPD and become wiser, and that fear of missing something should not be there. So what he is going to do today is exactly that. And as Satish said, catching Vijay is very difficult, like catching a new iPhone 14. I somehow requested him, and he agreed graciously to be on Navi Mumbai platform again. So welcome Vijay, and today's session will be moderated by none other than Dr. Amok Shahane, who is a EB member of Navi Mumbai IIP. She is a consultant at Sanvi Children's Hospital, Kharghar. So welcome Amok, and I request you to start the proceedings.
Thank you, sir. So hello friends, a warm welcome to all of you for today's session. As you all know, we have been seeing quite a few baffling cases in our office practice, especially in the post-COVID era, and many seemingly simple cases require extensive investigations and a strong clinical acumen to rule out underlying inflammatory disorders associated with them. So to help us to solve such googly cases, we have with us today our own master blaster, Dr. Vijay Vishwanathan, consultant pediatric rheumatologist at Jupiter Hospital, Thana, who in his own witty and hilarious style will take us through a plethora of cases, as in bones, chills, and pills, and of course thrills for all of us. So I'm sure you'll all be glued to your seats today for today's session, and I request sir to start off with his talk.
Yeah, before Vijay starts, I thank CIPLA for providing the unrestricted scientific grant for all academic activities whenever we take under. I request Mr. Abhay to say a word before we start.
Sir, thank you. Thanks to Navi Mumbai Pediatric Association for giving the opportunity to be a part of this wonderful session, sir. Thank you, Vijay, sir. Thank you, Jiten, sir.
Yeah. So, Vijay, stage is all yours.
Thank you, my dear Jitendra and Amok, for that kind welcome. I hope I'm audible.
Yes, you are audible.
Okay. And is my screen visible now?
Yes.
Right. So when so this talk was just out of the blue. When Jitendra and I were having a casual call, he said, "Why don't you talk on something different?" And which is probably justified by what Satish said. What are you talking on? Have you converted to an orthopedician by any chance? I said, "Majburi ka naam to banta hai, kahin se bhi patient nikal lo." And I'm going to talk on a few interesting things which I thought never existed in Navi Mumbai, and New Bombay seemed to be like a one-horse pony or a one-trick pony, that is Kawasaki disease. But so today's talk is going to be slightly different than what I normally do. It's going to be 3 things that I will be showing, which are probably not connected, but would be of much help in day-to-day OPD practice. So the first situation is tomorrow morning I'm sure one of the OPDs that the audiences are, you may see a hot swollen elbow like this, or a hot swollen ankle or a knee. And then most of us in New Bombay do an ESR, and either the ESR can come 120 or the ESR can come 40. So obviously it looks like a hot, swollen, shiny skin, and obviously the child is in a lot of pain. And no prizes for guessing this, that your first doubt is probably an infection, which is bone deep, or what's called as an osteomyelitis, right? So, and how do I sort out this mystery is, obviously, don't waste your patient's time and money on an X-ray. This needs an MRI, right? When you do an MRI, your MRI comes back something like this. So metaphysis, when it starts lighting up, so the first message I'm going to give you is, remember M for metaphyseal lightening and M for myelitis or malignancy. So when you start seeing a metaphyseal lytic lesion or a sclerotic lesion or a lesion that's a combination of both with a bit of periosteal elevation, you will call it osteomyelitis. And a very close differential is obviously to rule out the leukemia. Why am I talking to you about osteomyelitis? osteomyelitis is not just infection. From today onwards, let's start understanding that it and using the word inflammation. So the osteomyelitis could also be because of inflammation. What am I referring to? I'm going to talk to you about a condition which is as against the acute osteomyelitis, which is 8 in 100,000. This condition is extremely rare, 1 in 250,000 to a million. And the only Indian case series is about 6 cases in 5 years, which again justifies that it is not that common. But then I have seen 3 cases in 6 months. Again, doesn't do anything to justify the incidence, etc. But something to just sensitize the already sensitized New Bombay crowd was what made me think of this topic. So typically, this is how the patient, all the 3 of them came to me with, and these patients come to me from pediatric orthopedicians because they are the guys who have first access to the osteomyelitis case. And typically, in my OPD, Sandeep Vaidya calls me and says, I am referring your child with osteomyelitis. And I'm like, why do you call me for an osteomyelitis? He says, I don't think it's bacterial because it's recurred 3 times and I have operated twice. And 3 times it's happened in 3 different sites. And all the time the culture has always been sterile and the child recovers dramatically within 5 to 7 days. And ek bar dekh lena. That's the usual thing that he tells me. And then I'm like thinking, what has he told me? And he's giving me an answer. So he says that I'm referring a child which is osteomyelitis, but not bacterial. So I call it inflammation and non-bacterial. He says that it's recurred 3 times and operated 2 times. I say it is chronic and recurrent. He says it's different sites. I start using the word multifocal. And the cultures are always sterile. So it's a non-infectious osteomyelitis, which is where the word I'm going to introduce to the New Bombay crowd today is a condition called chronic non-bacterial osteomyelitis, or CNO, or it's also called as chronic recurrent multifocal osteomyelitis. Let's understand this through some cases. So this was a 15-month-old kid who came to me from BARC, and this child came to me when the child was 15 months of age, and his age was, when he was 4 months of age, the child had a right elbow pain with swelling, and hemoglobin was 5, and counts were not that greatly elevated, differentials not greatly exaggerated, platelets were okay, but severe anemia, and acute phase markers, CRP was 10, and ESR was not done. And this child was referred to the orthopedician who did an X-ray, which was normal. They did an MRI, which picked up lytic lesions and diagnosed as acute osteomyelitis. And before the surgery, they transfused, and the HB became 8.5 from 5. And this child got better and went home. And then after 2 months, he starts to have a similar story in the left elbow. And this time he's again advised surgery. And this time the parents say that we have had enough of surgeries. We will take, we won't go for the surgical story. And the patient starts NSAIDs and the child improves in 5 to 7 days. And then by the time the child is 15 months, there have been multiple attacks alternating the right and the left elbows. And then they come to me through a pediatrician who says there is something amiss. Please try to help me with this case. And all I could see was the pictures looked like a swollen elbow, but then there was something very unique. There were quite a few interesting cutaneous collection of erythematous papules all over the body. His serial CBCs revealed hemoglobin which was consistently low. And remember, iron deficiency anemias won't happen less than 6 months. RBC counts were consistently low, and acute phase markers were not greatly elevated. But then this child had a combination of the bone and this unusual looking erythematous skin lesions, which was mistaken for the usual Gamodia, etc. And this is how, when I saw this child, as much as this child used to get better with ibuprofen, he came to me with the left elbow this time, and you could sense that there is a terminal contracture already, thanks to the multiple episodes of osteomyelitis that was seemingly labeled as self-limiting. And this child was given a list of iron supplements to improve the hemoglobin. And I got an X-ray done, and this X-ray is already showing me areas of sclerosis and thickening. So almost telling you that it's a chronic process, or the right word that we use is hyperostosis. And then I looked at the previous X-rays, and you can see that there is a nice periosteal elevation. There is a combination of hyperostosis and sclerosis. So without bombarding you with too much of radiology, when you start seeing recurrent episodes of osteomyelitis at different sites, which kind of gets better with NSAIDs to come back again, you start thinking of some inflammatory condition as a cause. So the first thing that hit you was this child was a consanguineous marriage, recurrent episodes of osteomyelitis, which always was sterile on culture. There was some interesting erythematous dermatosis which was seen, and severe anemia of no explanation because nobody had worked up the anemia part of it. And what was striking with all these problems, he had normal acute phase reactants, or just about mildly deranged acute phase markers. So let's start with an anemia workup. And for the low RBC and low hemoglobin, the child actually had macrocytic anemia. Almost the MCV was close to 100. And anisopoikilocytosis was noted. The usual iron studies were borderline deranged. But then the gold standard would have been a bone marrow. So I got a bone marrow done, which was very consistent with this erythropoietic anemia, which seems to nicely fit into the picture because young age, young onset, you don't think deficiency anemias or megaloblastics can come at that age. So it seemingly fitted like a congenital dyserythropoietic anemia. And then I got a skin biopsy done, which was consistent with the pathologist came and said, this child has got sweet syndrome. What are you thinking about? So sweet syndrome is nothing but a lot of neutrophilic dermatosis, which can be seen in a host of conditions. But then when you start connecting the dots, you have a child who has a chronic osteomyelitis now. Almost surely it's non-bacterial because the child has got 8 episodes in 15 months. Surely left with a contracture. There is neutrophilic dermatosis, and there is congenital dyserythropoietic anemia against a backdrop of consanguinity. So if you read rheumatology, you will come across this condition called Majid syndrome. I mean, what's there in a name? It's extremely rare. There are only about 11 odd families that have been reported worldwide. And the classical triad is sweet syndrome, congenital dyserythropoietic anemia, and recurrent multifocal osteomyelitis. And it has a gene which is responsible, and we sent an exome sequencing, and this child tested positive for the LPIN2 mutation. It is extremely rare, but then you have something to offer as an explanation, if not a cure, because we still don't have access to IL-1 blockers in our country. The second case is even more interesting. I thought I have just seen my first case of CRMO, and within a week's time, this girl walks in, and this girl is I thought this is an adolescent girl who I asked what's wrong with this child, and mother was this very astute. The mother was a teacher, and she said this girl has been moonwalking. She's literally used the word moonwalking, and she's a fan of Michael Jackson, and I think that she's just fooling around. And none of the diseases in the medical textbook will probably explain this kind of a gait. So I thought this is probably a pain amplification syndrome or something. And I said, let's see what happens. And this girl has been complaining of vague pains in the leg. This girl is from UP, a 13-year-old girl, low fevers, not exactly documented, but on and off since the last 3-4 months. There is a lot of limping in the morning, so which obviously means that there is inflammatory arthritis, which was actually seen. The ankle joint was looking puffy. So whatever it was, the gait was unusual, but it was not explained by the arthritis. And obviously there was an element of inflammation there. And she came with this facial rash. And you would think about lupus, but this rash looks very unlike a lupusy rash. And examination revealed a bit of hip restriction, and we are always doubting UP, always, not always a male, but even females can have HLA-B27, enthesitis related arthritis, etc. And I said, let's do a basic blood counts, and she had already come with a ANA that was negative and an RA factor that was negative. So I did the logical thing is, let's do an MRI of the SI joint and hips, because that was seemingly restricted along with the ankle. And sure enough, the SI joint lit up showing sacroiliitis, and the ankle joint also picked up metaphyseal lesions at the lower end of the tibia, and it showed ankle joint synovitis. So I sent an HLA-B27, which came negative. And I'm like, it's what's wrong with this child? I can't make out. And then the mom says, what you're seeing in the skin right now is nothing as compared to 3 months back. So she goes home and sends the 3 months back of photographs. And then you start looking at this, and then you start thinking of the pediatric things that we have read. And this is nothing but, it looked like a lot of acneiform lesions. And this is what dermatology has taught us. Acne conglobata is the term, with a lot of florid, fulminant, pustular lesions. And then slowly the benefits of getting home at 7 o'clock starts sinking in. And I said, why don't I do an X-ray and see what's happening? Because this girl has been complaining of leg pain since 1 year, and we have been ignoring it. And then this X-ray again comes back. So every time you see an X-ray which shows bloated bones, especially in the diaphyseal or the diaphyseal and metaphyseal areas. And this girl has got a nice, similar to the previous kid, lot of sclerosis, periosteal elevation, and very coincidentally, the fibula also showed a mid-shaft lytic lesion. And then this gave a clue. This was a straightforward case. You start adding the words. You had ankle synovitis, you have acne, you have pustulosis, you have hyperostosis, and osteitis. You add all the first letters and you end up with an entity called SAPHO syndrome. So what is CRMO or CNO in the younger age group? The adult world, you start seeing more and more SAPHO syndromes. So again, a very, very distinct entity with a treatable solution. And once we diagnosed SAPHO, this girl, we put her on the right kind of medications. This is how she started improving within a month's time. So this moonwalking girl actually started walking reasonably normally, and the inflammations subsided, and she's on maintenance therapy. The third situation was, I almost thought I'm seeing a third case of CRMO, because I think I always remember Dr. Rashid Merchant's line that if you see a rare manifestation of a rare disease once, you are pretty sure that you are going to see it at least 3 times in the next few days to come. And this 18-month-old boy who came with low-grade fever since a month, refusal to walk and stand. So this, remember that stiffness may not be elicited in a young child. Loss of milestones can be the first manifestation of, especially the motor milestones, can be a manifestation of inflammatory disorders. This child was extremely irritable on touching also. And this time the counts were on the lower side, and P20, L65, platelets of 1.5. And then always the theory that we go by, platelets and ESR going in opposite direction, start getting worried. So I gave this child naproxen, and I advised for an X-ray. So 2 things happened. The X-ray showed me something similar to the previous ones, except that this was very, very lytic at the epiphyseal and the metaphyseal junction, which can happen in an 18-month-old because of the connectivity. And there was no response to naproxen. Unlike the previous 2 situations where ibuprofen had worked in the first case, and the second girl had improved on naproxen, this boy never improved. He kept on getting worse. MRI was very interestingly reported as multifocal osteomyelitis, because while there was a pickup on the elbow joint, there were also areas of increased lighting up on the knee joint also. Both the knees also lit up. So they reported it as CRMO, but something was amiss. This child was extremely cranky, counts were low, ESR was high, and 18-month-old should not have lymphocytic counts. First year of life, usually the CBCs we know, infants are lymphocyte predominant, but beyond 1.5 to 2 years, you should start seeing the reversal. And then I asked for a bone marrow because a suboptimal response to naproxen, like we have discussed on umpteen occasions, often points out to a bone marrow related story. And this boy turned out to be a malignancy. So remember that when you start seeing lymphocyte predominant CBCs in a leukopenic setting and no response to naproxen with a high ESR, please get the bone marrow out of the way if naproxen doesn't work as far as the pain is concerned. And then this is just to elicit one kid who first had a left thigh or the left lower end osteomyelitis, got operated. Then he then he was quiet for some time, and then the left one and the right one started getting involved. And we have two options for imaging, either an MRI or a FDG PET scan. And you can see that you screen for one on an MRI, whereas the PET scan picks up all hidden foci. Remember, the word I used was chronic, recurrent, multifocal. And this is how this the previous lesions behaved. And what happened after treatment, there is complete resolution of all the hyperlucencies that we are seeing here. What did we use is bisphosphonates. We leave the treatment part for some other day, but remember that the treatment, half of them will respond to NSAIDs alone. A few of them might need methotrexate, steroids. The worst ones will often benefit with pamidronates or biologics. So you end up treating them pretty much like JIA, but it's a different and a distinct entity. Spine can occasionally be involved. So when an adolescent girl comes with, or a boy comes with a backache, and you ask for an MRI and you see the body of the 3-4 vertebrae lit up, you may think it could be a malignancy. You rule out tuberculosis if it's one vertebrae which has collapsed. But if you see 3-4 of them with an ESR of 10 or 20 or 40, think that it could be CRMO. Unusual osteomyelitis if you start seeing. So this was a girl who came to me with a mandibular swelling. And very peculiarly, 1 year back, this girl actually had sternal osteomyelitis. So again, not very common sites for osteomyelitis. And when you start seeing this kind of a mandible with, again, ESR of 40, 50, not very high, and you do an MRI, you see interspersed areas of lysis with sclerosis. So start thinking of CRMO when you see a mandible like this. And then typically the biopsy will come non-specific osteomyelitis. Cultures will be sterile. So it is a sterile osteomyelitis. And then you will start thinking of CRMO. And with a timely pickup, this completely gets cured. You may have attacks, remissions, and relapses, but many times they don't come back again. So remember mandible as a clue. Another unusual bone where you can get CRMO is a clavicle. So other than the figure of 8, which is the only thing that most of us remember about the clavicle, if you start seeing a swollen up medial end of the clavicle, the sternoclavicular joint, etc., think that it could be a possible CRMO-like situation, and do an X-ray. It will pick up nice hyperostosis and sclerosis on the bones. So you may diagnose CRMO. This is just a picture I took from the net to sensitize the people who are working in the medical colleges who have continuous inflow of neonates in an infant who presents with such massive, dirty, angry lesions, which almost looks like atopy or psoriasis, etc. Think that there are certain genetic disorders which can have CRMO as a manifestation. So when you start seeing psoriasis, etc., in a young child, especially infantile age group, with or without the bone, start thinking of sending an exome sequencing, because there are newer conditions called deficiencies of interleukin-1 receptor antagonist, or DIRA, or interleukin-36 receptor antagonist. Tongue twisters, but then definitely manageable with the right kind of immunomodulation. So take-home message from this is, when you start seeing infantile psoriasis with or without osteomyelitis, start thinking of sending exome sequencing. So what is the take-home message from these slides? So from today, we know that there is an entity called chronic non-bacterial osteomyelitis. When do I think of it? Is either in a very young age or in an adolescent. In the young age, it keeps on having remission, relapsing courses, and the clinical features may not be that great. Definite pain is there with or without a swelling. And then you start reading words like lysis, osteitis, sclerosis in different combination. And remember, CRMO is nothing but clavicle, ramus of the mandible, long bones, and the spine. Acute phase markers not greatly elevated like the acute bacterial osteomyelitis. Always rule out a malignancy before diagnosing CRMO. It still remains a diagnosis of reasonable amount of exclusion. I said MRI versus PET CT, whichever is easily available, though people prefer doing a full body MRI. And when you start seeing a skin involvement at a very young age, or the neutrophilic dermatosis, your dermatologist might feed you these terms: hidradenitis suppurativa, acne conglobata, etc., etc. So, and then the trick is simple: you feed this child naproxen. A significant response to naproxen in a backdrop of osteomyelitis often rules out a leukemic process at least, and then you end up doing a biopsy. And why is it important to know this condition is as rare as it is? There is the reported delay to diagnosis is almost 3.5 years. And if you read literature, there are kids who are adolescents who've been having pain for the last 5 years, 7 years without a diagnosis. And just do an X-ray and you see such thick hyperostotic bones, and you end up diagnosing CRMO. So rare, but definitely exists in Navi Mumbai and Thane, where we all practice. So it's just a matter of you may feed these cases to the orthopedician. The orthopedician may do the surgery once, but if this child comes back to you again and again with osteomyelitis like presentation, while we are justified in thinking of immune deficiencies, etc., as the primary cause, but remember that an FDG PET or a full body MRI may not be a bad way to begin, right? Now, the second part of my talk is what is very rampant in the pediatric OPDs these days. And somewhere we are used to seeing a lot of infections. So this slide is, I think most of you have seen this slide. So pediatric rheumatology or inflammatory fevers, we all know, is high grade fevers, usually once or twice or thrice. It's never a continuous fever unless it complicates into something else. And the child is absolutely fine in between the fever spikes. This is the age-old definition of inflammatory fevers. And I keep saying that pediatricians and the parents are often happy when the fevers resolve, whereas I start getting interested only when the disease actually evolves. And when do I think of inflammatory fevers? I think of it always, because that's what I do in my OPD. And the same reason you have heard from my mouth 100 times is I only have 10 diseases which are seemingly uncommon to rule out, whereas the pediatrician has got 1,000 infections, 500 malignancies, and then rheumatology ka number kabhi aata nahi hai, right? So the first slide about whenever in a busy OPD, you have an indoor patient who's just not responding to anything that you have done. For all practical purpose, I'm going to say that the cases I'm going to show is fever for more than a week or 10 days. Remember to use the naproxen test after a week of fever, because by that time, most of your typhoid, malaria, dengue, rickettsia, etc., would have been reasonably ruled out. And if the child actually has additional musculoskeletal symptoms, then it is worthwhile doing a naproxen test. What is a naproxen test? You give the child 10 mg per kg per dose twice a day of naproxen for 3 days. If both the fever and the arthralgias and bone pains respond, you are looking at a straight inflammatory pathology and you ring me up or WhatsApp me up. If the fever responds, but the joint pains persist, like we saw in the previous kid, you are almost sure that you are looking at a bone marrow related problem, because the marrow pain due to the blast proliferation does not respond to naproxen. So please do a bone marrow in that child. And if both of them don't respond, neither the fever goes away, child is still spiking, and the arthralgia still continues, you will intensify your search for an hidden infection. So like tuberculosis or a retroperitoneal collection or an FDG PET, again, all over the world is coming up in the diagnostic algorithm for fever of unknown origins, right? So simple thing, a naproxen test will give you at least a starting point to how to proceed. And then my way of understanding fever is I call it pyrocytosis or pyropenias. Pyrocytosis is obviously when the child is having high spikes, and these are common 4 reasons in rheumatology, of which only the first one is the most common in our part of the world. And obvious catch is that I will rule out tuberculosis and occult infections before thinking of these 4, which by the time the patient comes to me, most of the kids would have undergone. So these are 2 kids I saw last month, and the numbers have gradually increased since the COVID pandemic. And I'm trying to figure out why, because no prizes for guessing what is the diagnosis. We've seen this so many times in an OPD. A child, a 2-year-old comes with fever for 10 days, and there are fixed 3 spikes at fixed time, 8 o'clock in the morning, 4 o'clock in the evening, 10 o'clock in the night. Extremely high grade fevers, 103, 104. In between, the child is absolutely fine. When the child gets fever, is supremely dull. Versus a 9-year-old girl who has fever for 3 weeks, and she has a very, very typical once a day fever spike in the evenings, well in between the spikes. So we will call both these fever patterns as intermittent and quotidian fever. So remember that quotidian fever has got very few differentials. You would think of tuberculosis and systemic onset JIA as the most commonest differentials that we will see. And by the time the child reaches me, infection workup, cultures, everything is no growth, and the child is on multiple antibiotics and not responding. And then you do only a CBC. HB comes back as 8, white cells come back as 18,000, neutrophilic predominance, platelets are extremely high. So I'm extremely happy when all the things are moving in the same direction. CRP is high and the ESR is also high. What is one test if you would want me to do? And now we are wiser that egg free, we will do an naproxen test and we will ask for a ferritin. Remember, this is a tailor-made situation for sending a ferritin level, because everything is pro-inflammatory. The child seems to be extremely happy when there is no fever. This is the textbook definition of a systemic arthritis in evolution, because we don't know still if the child has got a rash or not. And sure enough, the naproxen test will come positive, because this child's fever will disappear. The 3 spikes per day will become 2 spikes. The 2 will become 1. 1 will become once in 3 days. So a intermittent quotidian pattern at the onset, if it's not there, the naproxen converts the fever pattern into a quotidian fever. Again, giving you a clue that you may be looking at a possible systemic arthritis. And when counts are high, platelets are high, ESR is high, CRP is high, everything is inflammatory. So life is happy, and you do a ferritin and surely it's going to come deranged. For people who have not seen a systemic onset rash, the parents may not notice. You may not ask. That's the problem. So every time you see a once a day fever or a twice a day fever and a happy child, ask the parents to definitely look out for a rash, upper arms, the trunk, the chest, the back, and you may see a pattern of rashes. The classical definition is a salmon pink evanescent rash, which means the rash increases when there is fever and the rash fades away when the fever goes away, may not disappear. you may have urticarial lesions. So remember, before you give the next prescription for a steroid in a busy OPD, when you see urticaria, if the patient says pitta sarka aahe पण खाजवत nahi, think twice that usual urticarias will be supremely itchy. And there are a proportion of systemics which also itch, and they come with this what is called as Kobner's phenomenon or dermographism, which is also a reasonably sensitive marker of a systemic JIA. But then urticaria which doesn't itch, often take it with a bit of caution, because that is a condition where you may not want to use anything beyond an Atarax and a calamine lotion to see how she evolves or progresses. And urticaria with high grade fever, please stay away from steroids at least for the first 3 to 5 days, unless you have significant evidence that it's nothing sinister, right? This was another kid I saw from Panvel, and this is the kid who's having fever for 5 weeks and 2 spikes per day. And this child had every single thing that the book says, hepatosplenomegaly, and this kid was so scratchy. There was so much of scratch marks, which is exaggerated, which is nothing but Kobner's phenomenon. And then on the 3rd week of illness, this child started having arthritis. So everything fitted in nicely. Ferritin came back high, ESR high, CRP high, the prototype systemic onset JI. Remember, SJI patients are extremely rampant in our part of the world, and it just needs a careful history taking and less of mefenamic acid. And if you are using a mefenamic acid, educate the parent to keep a temperature chart regularly, because like we all know, the history of fever is very, very crucial. And the history of fever without getting corrupted with a strong NSAID becomes very important in this situation. So once a day fever, happy child in between, quotidian fever. 2 times in between happy, quotidian fever. With or without dermatographism, arthritis, hepatosplenomegaly, think of SGIA, rule out tuberculosis, send ferritin, do an naproxen test, everything will flow easily. This is just to finish off the story. This is the intermittent quotidian pattern that all of us know how it looks like. Many systemic arthritis have bicipital tenosynovitis, rare thing which looks like an axillary gland, but it's actually, if you notice, it's a biceps tenosynovitis. So tenosynovitis, neck pain and wrist joint pain is very, very typical of a systemic onset GI. So if you see a child with a neck pain, a wrist joint swelling with high fevers, think that you may be looking at a systemic GI. Occasionally, you will have polyserositis, pericardial effusion, etc. Then how do you work up a systemic arthritis? Once you know that this is an intermittent quotidian fever, happy child in between fever, but I am thinking SJI. So you will do the whole workup in one shot, no shortcuts with SJI. And you may have these 2 types of situations. Anemia of chronic inflammation is universal. Counts can either be 25,000 with neutrophilic predominance and very high platelets. Ferritin comes 1500. That's enough to suggest that you are looking at possible inflammation. Only thing left is to rule out tuberculosis, probable malignancies by a CT scan, and then you are set to go. LDH will be high. SGOT will be deranged about 2 to 3 times. Fibrinogen will be very high. So the cutoff value that we look at from SJI point of view is 360. The ESR was obviously very high. CRP comes in 3 digits. You do a triglyceride on a fasting sample, it's mildly deranged. This is what I call as the confirmatory, angry, inflammatory phase of systemic arthritis. Now, if you think that this child is SJIN, but you get a report which is like this, so the counts instead of 25,000 is 2,500. The platelets instead of 6 lakhs is 60,000. This child suddenly, from being a happy child, by the time the child reaches week 3, week 4, becomes sick. Ferritin starts really climbing up. LDH is very high. Transamine acid sets in. The child becomes encephalopathic. And then your CRP is high. The fibrinogen, this is a typo. The fibrinogen will start dropping and the triglycerides will start climbing up. You know that this is a macrophage activation syndrome. So remember that there are 2 phases of SJIA, or 2 avatars as I call it. Both of them are possible and both of them are the part of the same coin. Systemic arthritis, ongoing inflammation without treatment will crash into macrophage activation and vice versa. A macrophage activation can be the first presenting feature of systemic arthritis. You diagnose a MAS based on a ferritin of 5,000. You may call it HLH, give Solumedrol, get the kid out of trouble, and then this child will start manifesting with a rash, joint, etc. So both situations can happen at onset. Where does the pediatrician's headache start? It starts at 10 p.m. and my headache starts at 11 p.m. because the pediatrician will start calling me at 11 and he will think from 10 o'clock ki Vijay 11 baje phone nahi utayega. That's a possibility, right? And these are three situations which give pediatricians a headache. This is what has been my experience in the last 5 to 7 years in the monsoons. The first kid is a 5-year-old girl. Sib has got dengue, fever for 7 days, biphasic fever, dengue NS1 positive, on the way to becoming IgM positive. But the fever is not breaking. Instead of getting better by day 5, day 6, fever keeps on increasing and the toxicity is increasing. The child is becoming dull. Urine output is a bit low. Oral intake is down. A bit of transaminitis are there and you have done all the cultures which are sterile. What do you do? The second situation is a 9-year-old girl who has a step ladder pattern now becoming continuous after 10 days. Cultures are no growth, but we pile on to Vidal as much as we don't believe in it. It comes borderline positive and then there is no response to antibiotics. What do you do in such a situation? You are treating her like enteric fever, but it's not responding. And the third is not that uncommon. 12-year-old who comes with fever, rash on the palms and soles, day 7 of fever, and increasing toxicity. And there is a suboptimal response to antibiotics. What do you do in such a situation? You know that you are dealing with dengue in the first case, enteric fever in the second, and probably a rickettsial fever in the third situation. The palms and soles rash, monsoons is Maltese gut season, if not Solapur ka patient. Most of us keep on traveling, and then rickettsia is often a possibility, right? And there are known causes of macrophage activation. No prizes for guessing that a seemingly normal infection, if it starts to misbehave, think that rather than changing the primary diagnosis, think of a possible inflammation getting complicated. And the commonest complication of all these infections is macrophage activation syndrome. What do you do in this situation? So in the dengue patient, you may wait and watch for cell resolution. For the enteric fever, you may be bold enough to say, I will add azithromycin and see what happens. And the third situation, you may do a wheel Felix and a doxycycline, and age-old, again, the theory that 3 days of doxycycline, the fever goes away, you are seeing rickettsia. Because many often what happens is by the time the veil Felix comes, the patient is already afebrile, right? So all three things are probably justified in this situation. But what happens if you refer this child to me and I advise to do a full HLH workup, which I normally ask, and then I only do the workup, I don't necessarily act. So the first situation that is possible is ferritin comes back 2,500. The ESR is low compared to the CRP. The fibrinogen is, now we know that the cutoff for fibrinogen in all this situation is 360. So 240 is low, explaining the lowish ESR. LDH is slightly deranged. And the triglyceride, the cutoff is, remember, triglyceride 160, fibrinogen 360. More than 160 is high, less than 360, fibrinogen is low, right? And then you will say, this is macrophage activation. Let's see how doxycycline works in the rickettsial story, how AZI works in the enteric story, and the dengue might just get better on its own. So after 48 hours, sure enough, there are more number of patients, so the fever will go away. The ferritin, if you repeat, will start falling down. The markers will start settling down. Possibility number 1, 60 to 70% of post-infectious HLH only needs a careful monitoring of the vitals and hemodynamics. They will get better. In about a quarter of them, the child just keeps on increasing. The fever spikes increasing. The toxicity increases. And when you repeat, so this is a situation where you will not cut costs. please do not stick to only ferritin alone. You have to commit to the full story because you are dealing with a potentially life-threatening situation. If the child is getting better, I may not do the full gamut of tests. I may just stick myself to a ferritin. But if the child is becoming sicker and sicker, you will do the full thing. And then sure enough, the ferritin climbs up to 14,500. And these are all live cases in New Bombay. And this kid obviously failed the antibiotics, escalated to doxycycline, azithromycin, and then we gave solumedrol and treated with the HLH 2004 protocol. And obviously the entry kid turned out to be EBV positive, which is the most commonest cause of HLH in the pediatric age group, like we know. And once you give the steroids, the first thing is, how do I assess if the child is getting better? Remember, ferritin has a very short half-life, so that ferritin and fever should come down within 48 hours. If both are coming down, then you know that you are probably, got out of trouble. And the clinical improvement will dictate how often how do you taper the steroids and when to stop. If you end up listening to me overzealously and do the full workup every 72 hours, you may not be surprised to see the fibrinogen and triglycerides increasing, but the ferritin is dropping, child is getting better. So I keep getting phone calls ki, fever chala gaya, ferritin 14,000 ka 1200 ho gaya, but triglycerides abhi bhi zyada aa raha hai, right? So remember that the whole reason for doing all the tests at one shot is macrophage activation is a dynamic process. One thing will get better at the onset, but the recovery, each one will take its own sweet course. So like you have the CRP, which goes up and comes down quickly. ESR is slow to rise up, slow to come down, which probably mimics the fibrinogen in the body. And the triglycerides will probably be the last to come down, right? Which is where once the fever and ferritin are in the positive direction, I won't chase the fibrinogens and triglycerides, right? So this is how you would approach a potential persistent common infections, fever not breaking from a rheumatology point of view, not very difficult. And you know that the common infections that we encounter, we've seen enough of EBVs, salmonella, dengue, mycoplasma, and rickettsia. These are the common infections that I keep getting referred patients to. Most of the time, I think of an HLH to start the thinking process. I know that many of them will not need steroids. The idea is to document one baseline macrophage activation profile and a good clinical watch for the next 2 to 3 days. And then few of them might need steroids and cyclosporin, etc. But we'll keep that for the rarer part of it. We won't talk about it much. So the take-home message is when you see a known diagnosed infection, which is not responsive to your regular level of treatment, think that you are probably looking at an inflammatory complication. And you can obviously phone a friend or WhatsApp a friend, I suppose. So the next situation is, again, because the introduction was wheezes and sneezes, I thought I should have this girl. I have only seen one of this kind in the last 12 years of my OPD. And this girl came to me from MGM Medical College, which I think the MGM people would be knowing. This was an 11-year-old girl who walks in without an appointment and on a busy day. And I say, 11-year-old girl, all of us know that fever on and off 6 months, symmetrical large and small joints, so definitely looking like polyarthritis and morning stiffness. But then very interestingly, this child had lost 4 kgs over 6 months. But it was a busy OPD, and I said, this looks very, very JIA, and the parents look not very educated, etc. And I said, and I see the blood reports and 15,000 counts, unremarkable, ESR 75. And I said, let's start. RF was negative, ANA was negative. So lupus is ruled out. Let's start her treatment as a polyarticular JIA, right? And then we put her on steroids and methotrexate, and like most of the patients, they stopped treating after 3 months because the steroids worked. And then she got readmitted with a same arthritis and rash. And this time the rash looks reasonably vasculitic. Remember, when you see a rash like this, you will always think a small vessel disease. And then you repeat the blood tests. Counts are high, neutrophilic. But then very interestingly, a detailed history, because this time the patient walks in with a proper appointment on a day which was quiet. And then you start thinking of digging deep, because this rash looks vasculitis. She never had an RF which was strongly positive. She had systemic symptoms in the form of weight loss. And as it turned out, lot of papers of a pediatrician visit for wheezing, cough, cold in the last 2 years. So from age 10 or age 9 to age 11, this child has made multiple visits to the pediatrician for colds and coughs. And every single cough syrup she's received, every single nebulization she's received, lots of references of wheezing. So remember, a child who has fever and wheezing, you will really start thinking, is this normal? Is this so many episodes of viral, so many episodes in asthma? So obviously there was enough new clues that came out. And then I saw all the serial CBCs. What was very unique and uniquely missed out also was this child kept on having eosinophils of 25%, 19%, 24%. And the counts and platelets were suggestive of inflammation, and ESRs were supremely inflamed. Now the puzzle becomes very easy, because on some other day you would have started DEC, deworm this child, etc. Or you would have ignored saying, we wheeze hai to eosinophils to high aane wala hai, right? But aisa rash nahi aata hai, and then obviously you don't have a 3-digit ESR. And then we said, why should a 10-year-old have recurrent episodes and colds and coughs? So this is where so my training teaches me that when you start having atopy, allergy, asthma like presentation with musculoskeletal and supreme inflammation, start thinking of small vessel vasculitis with these lesions. And we did a CT scan which said pansinusitis, and the lung CT came up with the best pictures that I can ever think of. Had lots of ground glass opacities, nodules, bronchiectasis, you name it, and this child had every single inflammatory presentation, suggesting of what is called as ANCA-associated vasculitis. So the next time you see an urticaria, think twice before giving steroids. A child who keeps on coming with recurrent wheezing, and musculoskeletal with or without a skin, you will start thinking of something which used to be called as Schergstrauss syndrome, which these days are called as eosinophilic granuloma with polyangiitis. So that's EGPA. Without the eosinophilia, you would start thinking of calling it a Wegener's disease or a Wegener's granulomatosis, which is now called only granulomatosis with polyangiitis. So what's the clue for ANCA-associated vasculitis? A combination of recurrent sinusitis and pulmonary involvement and renal. So proteinuria. Remember that urine, do not settle for a urine routine. It may be normal. Always insist for a first or a second sample urine PC ratio. And when you start seeing such horrific images on a CT, you are almost sure that you are looking at an ANCA, and you send the ANCA and it will come positive, right? From cytosis, we'll go to cytopenia. So cytopenic fevers. So this is again a very common situation. A 6-year-old female who's admitted for fever for 2 weeks, and then the fever is high grade, intermittent with night sweats. There may be a lymph node that you palpate, and now in the second week, this child starts to have arthralgias. And the usual story, Vidal 1 in 100, counts are low, but remember that when you start seeing counts low, if it is leukopenia along with lymphopenia and the platelets are low, you always will throw in a CRP and an ESR like we do, and the CRP comes negative and the ESR is 40. This is a situation where I'm straight looking at a female with low counts and a CRP that's negative. This is obviously, you will think of lupus as a strong possibility. And you just do a urine PC ratio comes deranged, send a C3, C4 and an ANA as a screening thing, which is very, very doable in the pediatric setup. While you keep treating for the enteric fever, it hardly takes, you don't even need a blood sample. If the urine shows a lot of proteinuria, more than 0.5, start thinking in terms of a lupus-like disease. And the clue is simple: anemia, lymphopenia, leukopenia, low platelets, or lowish platelets. Remember, the low platelet from rheumatology is less than 2 lakhs. You don't wait for 30,000, right? And a negative CRP and a slightly elevated ESR should make you think of lupus. And then you can confirm the diagnosis by sending a blot. On some other day, if the cervical swelling comes and really hits you hard, you don't do an FNAC. What has been my experience is FNACs generally are not that conclusive in the subacute to chronic story, and you will eventually end up with a dilemma. So better is to do a lymph node biopsy, and you may come with this fancy report which says necrotizing histiocytic lymphadenitis, or what used to be called as Kikuchi-Fujimoto's disease, with a big host of differentials, including SLE, lymphoma, tuberculosis, cat scratch disease, etc., etc. And the biopsy makes the life so easy. So do not again cut costs for logistic issues. These are sick children who we want active and quick diagnosis. So either I send the lupus workup, which is easy to do, but may be expensive, or you start from the site of crime, remove the lymph node, and you end up with a diagnosis, right? These are two kids I wanted to show only because there is nothing unique, but occasionally I do get references from gynecologists and obstetricians. These were two girls who were 12-year-olds, and both were given a label of ITP. In fact, one patient's mother said, "हमारे तो नसीब ही खराब है, 40,000 के ऊपर तो हमारा प्लेटलेट जाता ही नहीं है कभी." But डॉक्टर ने बोला है कि कभी भी bleeding नहीं होगा. And both of them ended up in the casualty with menorrhagia, right? And very peculiarly, as much as they were labeled as chronic ITP, they also underwent an ANA, which was strongly positive but was ignored. The first kid, while she was assured that she will never bleed, presented with a sagittal venous sinus thrombosis after 1 year into the diagnosis of chronic ITP. So while she never bled, nobody would have thought that she can clot also. And she received anticoagulation without any major dramas. And then she comes back this time around with fever for a month and then menorrhagia. And when the CBC is done, the HB is low, the white cells are low, and platelet is very low, right? So something is fishy, you know. So this is a child who almost threatens to bleed, but ends up getting clots. You will end up thinking inflammatory. When you have this bleeding clotting kind of a story and a slowly progressive disease in a 12-year-old girl, right? The kid on the right was, in fact, ANA 1 in 1,000. You should have done an ANA blot at that stage, but you didn't. You labeled her 12-year-old as a chronic ITP. And this time when she presents with menorrhagia, a detailed workup done, her HB was very low. So an anemia workup done came back positive for hemolysis. Platelets were low. So it becomes autoimmune hemolysis with thrombocytopenia. And then the most fancy word is Evan syndrome, or Evan syndrome, as we call it. So Evan syndrome is nothing but autoimmune hemolytic anemia with thrombocytopenia. And how do I get out of this misery? Same, both the differentials were lymphopenia and leukopenia, and both of them had a negative CRP and a high ESR. And sure enough, both of them ended up getting diagnosed as SLE, right? The only message I want to send is why it seems a very routine thing, right? But when you call something chronic and autoimmune, please rule out the mother autoimmune disease, that is SLE. You don't need to see a butterfly rash always or a hard palate ulcer always. So many times you will see the hard palate ulcer more than the butterfly. But when you start hearing words like chronic ITP in an unusual age, a nephrotic at an unusual age, an adolescent female, unexplained encephalopathy, thrombotic episodes, anything autoimmune encephalitis, autoimmune thyroiditis, autoimmune hepatitis, think that rather than calling it as an isolated disease, try ruling out SLE, because all these things can be a part of the lupus which is there. And anytime you see a girl in trouble, please think of lupus as a possibility, right? So take home message from pyropenias is lymphopenias with prolonged fever. Lymphopenia is lupus. Kikuchi and lymphoma have to be sorted out. When you have leukopenia with high lymphocytes, ESR and platelets going in opposite direction, like that young kid we saw, please rule out leukemia. And the test I told you is no response to naproxen as far as the pain is concerned. And then when you have leukopenia with high fever, a very high CRP, sick looking child, we now are very confident in diagnosing macrophage activation syndrome. And I will probably urge that if possible, do a biopsy rather than spending time on FNAC, because that may not be conclusive, right? So we know pyrocytosis, most common systemic arthritis, ruling out tuberculosis and malignancies. Vasculitis, we know more or less. Medium vessel is PAN, Kawasaki. I showed you an example of a small vessel disease. And we know that early infantile fevers can be auto-inflammatory, which we had briefly discussed at the flirt meeting, right? And when you have low counts, there are very few things from rheumatology that you have to rule out. The pediatrician starts off with dengue and typhoid. The rheumatologist starts off with lupus and Kikuchi's and sick child macrophage activation. Obviously, malignancies lead you with basic tests. So the last part of my talk is I just wanted to briefly show you what my armamentarium looks like. So all of us know the word disease modifying anti-rheumatology drugs or anti-rheumatic drugs. So you have categories called synthetic DMARDs, which is the usual conventional synthetic DMARDs, as it's also called as. So methotrexate, azathioprine, cyclophosphamide, cyclosporin. These are the different conventional synthetic DMARDs for, and each of them has a specific role in some diseases. Where we are heading towards is the biologicals, which have made a world of difference in the pediatric rheumatology world. And then they go by, you actually are picking up the cytokines, which is causing the mischief and blocking them. And then I thought I should just scare you with these new names or terminologies. So most of us know monoclonal antibodies. So depending on whether it's murine or chimeric or humanized or human, you will start hearing terminologies called OMAB, ZMAB, UMAB, or ZUMAB, right? So COVID has taught us tocilizumab. We all know adalimumab, infliximab, rituximab, etc., etc. So tongue twisters, but I'll show you two slides where it makes the effort worthwhile. And where are we moving towards is targeted synthetic DMARDs, which are also, thanks to COVID, many of us are now aware of drugs like baricitinib or tofacitinib, which are Janus kinase inhibitors. All this is tend to understand, but what we can't deny is the surgical, the glue that holds all of them is steroids still, right? So I'm going to talk to you about steroids only because
the form. We will go and give the form tomorrow. I have to go and get form 16 and blah blah blah.
Dr. Amol, please mute.
I will submit. Then approval होके नहीं आने वाले 2 दिन में.
Hello, yeah. So I think most of the New Bombay crowd know this slide a lot because I've shown them enough of this slide. But what is very catchy is the last line is often what I get sent off on my holidays. And our dear president always says, Vijay aane tak steroid is his best locum. Steroid dete raho, which I always say that dena chahiye, but with a logic and a reason, right? My problem after COVID is steroid to dega, but 2 se ki 10 se ki 30 se. That is something which has become a universal problem for me. And I can't wait for the pandemic to end, because once the pandemic ends, the one bad habit or the unusual habit that it has introduced in our lives is this 10 mg business, right? So what is the logic of 2 versus 10 versus 30 was what I thought I should finish off this talk with. This is a crowded slide, but if you don't know this slide, we should not go to OPD tomorrow, right? This is the only part of rheumatology that all the pediatricians, however busy the practice might be, should be aware of. What is the approximate equivalent dose of steroids? So remember, the steroids can be categorized as short acting, medium acting, and long acting based on the half-life. So the short acting ones is your F-Corlin or hydrocortisone. Short half-life less than 12 hours. The prednisolone, and deflazacort are the medium acting with a half-life of up to 36 hours. And the dexamethasone is the long-acting, better CNS penetrative steroid with a half-life of 36 to 72 hours. Once we know this, all I need you to take note of is 0.75 milligrams of dexa. Just attach this in front of your window or a mirror, and just keep staring at this till you become a professional. This is easy. 0.75 of dexa equals 4 mg of methylpred. And remember 4, 5, 6. 4 of methylpred, 5 of pred, 6 of deflazacort, which we hardly use, but you may see the occasional Duchenne's dystrophy on deflazacort, right? Which is equal to 20 mg of hydrocortisone. This comes handy, right? That's rule number 1. What is the 2, 10, 30 wala business? So this is the last few slides, I promise. So a 7-year-old who weighs 30 kgs, who needs steroids. So 30 kgs, if you give oral 2 mg per kg, he is taking 60 mg per day, which we know is a high dose despite being 2 mg per kg of prednisolone. If you convert it into 2 mg per kg of MPS, which is the usual query that most of us have, methylpred dena hai 2 se ki 10 se ki 30, you are giving a 75 mg prednisolone, which is a supranormal dose for routine inflammatory stuff. If I give 10 mg, you are giving 375 mg equivalent of prednisolone per day. And if I am giving my favorite 30 mg pulse, imagine the dose of oral pred equivalent that's going, right? So obviously, more than the numbers, it is the rapidity of action that is needed, which is going to decide what dose of MPS are we giving. What do I mean by that is, if we go back to physiology, the steroids work in 2 ways, non-genomic and genomic. The conventional anti-inflammatory doses of steroids, for all practical purposes, like we know, is low doses when the patient is on less than 7.5 milligrams a day. A moderate dose is 7.5 to 30 per day. A high dose is more than 30 per day. Whereas a pulse therapy is more than 250 mg per day. Now, most of this action happens through the genomic mechanism, where the prednisolone that we are giving enters the cell, penetrates in the nucleus, and by binding to the intracellular receptor, and there is genomic interaction, and then there is protein synthesis. So it's reasonably long acting, but it starts kicking in late. Whereas the non-genomic or the 30 mg per kg pulse dose is something which works within a matter of seconds. So that is the non-genomic, means you don't wait for the steroid molecule to enter the nucleus. It starts working as soon as it binds to the cell and the membrane receptors. So it starts as soon as it enters the cell, within seconds, the activity starts. That's the non-genomic action. So when the COVID guidelines were being formed, the infectious disease people were skeptical about giving a very high dose of steroid, a pulse dose of 30, because they were worried that the viremia will flare, especially in the adult world, right? We know that adults have low immunity, etc. But then the compromise was that there was 2 or 3 rheumatologists in that consensus group, and they decided that neither 2 nor 30. At dose of 10 mg per kg MPS, the non-genomic action starts setting in without actually going to the real immunosuppressive dose, which is where the 10 mg per kg doses started creeping in. So it's almost like a sunscreen lotion with the SPF of up to 25 makes the difference. So a 25 SPF works better than a 10, but a 25 or a 50 may probably work as good as the other one. So a 10 mg per kg MPS or a 30 mg per kg dose almost works the same, except it looks lesser. But then eventually, when it comes to immunosuppression, all the 3 doses are equally bad or equally good. You are worried about what is the urgency of the situation vis-a-vis emergency of the situation, because a sick child, you can't wait for a 2 mg to start working. And a happy child, you're not looking at giving a humongous pulse. But common indications where pulse doses are used, 30 mg per kg, will probably be the norm post-COVID, right? So remember, the genomic dose is the 2 mg per kg dose, and the non-genomic rapid acting dose is the 30 mg or the pulse therapy, right? The last slide is on adverse effects, which will affect you as a pediatrician as well as me. Me probably because of long-term duration of the steroids. Most of us know the duration-related side effects of steroids, but as a pediatrician who's busy in the OPD, a child who comes from me with the diagnosis of a lupus on a high dose of steroids will come to you and saying खातच राहतो, जेवण खूप जास्त करतोय, चिप्स देऊ शकतो का, रात्री झोपच नाही, आणि उलट्यासारखं करतो, मळमळ होतो. So the commonest side effects that I encounter in the first 1 month of a 30-40 mg per day is mood fluctuations and sleep disturbances. Often we don't pay much attention to the sleep disturbances part of it. We just focus our attention to the appetite. So obviously a little bit of diet counseling becomes paramount. Please make sure that the child gets a reasonable cover of an antacid SOS. Arthralgias and backaches are extremely common with a high dose methylpred pulse. Sugar lipids can go crazy, need not be addressed generally, settles down. And so the way I understand the pediatric solution is A for appetite, B for blood pressure has to be checked at every visit. Bone health has to be taken care of because maximum bone loss happens in the first 6 months to a year. Cutaneous, so the striae and stretch marks are often a very, very sensitive issue because we know that the stretch marks don't regress back to normal. So the idea is to balance the steroid dose. If the pediatrician is using the steroid, use it as much as you need and come down as soon as possible. In rheumatology, it's easy for me because I start the child on DMARD, so tapering the steroid becomes easy, right? Please make sure that the diet is addressed, the eyes get checked, especially my patients, if they are not following up with me and they are following up with you, it's often a good idea to check intraocular pressure or cataract, retinal involvement, etc. The general fatigability, the general condition of the muscles, most important is the growth, right? So as pediatricians, we are responsible for ensuring long-term growth, blood pressure, metabolic things, and last but not the least, we should obviously keep a watch for infections. And this is one situation none of my patients should shy away from getting the extra vaccinations. Beg, buy, borrow, steal, but the last thing you want is a child with rheumatology succumbing to an infection. And infections and rheumatology equals macrophage activation syndrome. Extremely bad combination, right? So last rule is, because Amol was just interrupting, I just thought I should add this slide. I knew that he will interrupt. No offenses, but I very rarely use 2 milligram per kg, and I leave the 2 mg per kg doses to the nephrologist because the nephrotics are someone which can become a possible pain for them, right? For the patient as well as the doctor. So most of the rheumatology patients that I see usually get 3 to 5 pulses of Solumedrol. And then the advantage of giving this high dose pulse non-genomic. So let's start using the word non-genomic ki genomic. Rather than 2 ki 10 ki 30, you ask non-genomic ki genomic, right? So it's one way of convincing yourself, ye bacha urgent hai ki emergency hai, right? And then you will get away with 1 mg per kg as a reasonable anti-inflammatory dose. And then the idea is to gradually slow down to 0.3 to 0.5 over 3 to 6 months. Remember, the nephrologist and the pediatric training always teaches about hypothalamo-pituitary axis suppression. So the PA axis suppression, to avoid that, we always have been advised to take 8 AM cortisol and take the prednisolone in the morning as a single dose. So I have often found that taking 60 milligrams of prednisolone causes significant gastritis. And the thinking in rheumatology is TDS dosing of steroids. So 20 TDS works more efficacious than 60 OD, with the compromise that a single dose causes less suppression and a TDS dose causes more suppression. But most of the times, the situation demands the dosing. A sick child needs more efficacy. You're not bothered about suppression. So you give a TDS dose. and then gradually start reduction. And by the time I reach 10 mg, then you may tape. That's what I do. Less than 10 mg, I switch over to a single dose. Till that time, most of the kids will get a TDS dosing. And then obviously in all of my patients, early use of DMARDs is the rule, which helps me taper the therapy. So I showed you a lot of complicated names of the biologics, and this is how, as difficult as it may sound, this was a child, and this is just to show how the biologics have helped. This child was having quotidian fever, which became continuous, and this child was systemic arthritis with macrophage activation. And I managed this girl in a nursing home. This girl with 3 pulses of Solumedrol became better, and after 7 days, she comes back with a nice haircut, and she's settling nicely. In 4 to 6 weeks, she gets the rheumatology ISI stamp. She becomes supremely Cushingoid because she was having a ferritin of 15,000 and absolutely no resources. She comes from a very remote village in Maharashtra, and the very, very astute father. This girl becomes this on thalidomide because the farm season decides whether this girl gets tocilizumab or thalidomide. So I put her on thalidomide, which is the poor man's tocilizumab, and she did brilliantly. And 1 year there was a bumper crop, and the child got switched to tocilizumab. And see the difference from a child who is supremely sick. This is a complete revolution and resolution which the new age biologics have started. So all the pediatricians nowadays know Actemra better than their left hand. So Actemra is nothing but an IL-6 receptor blocker, which we have used in a lot of MIAC patients, and the classical indication is a bad systemic arthritis, right? So this is one story which I wanted to share, and this again was when you were getting initiated into etanercepts or etacepts or intacepts, the TNF alpha blocker generation. This again, the first patient was courtesy MGM Institute, Kamote, and I'm pretty sure Jitendra would remember this kid, a very typical 8-year-old boy limping from Nanded, and ankle tarsitis, knee sacroiliitis, and supremely unconditioned. And this boy, we started giving him TNF alpha blocker at diagnosis because we could arrange for some charity. And this is the difference. In 1 year, this child has put on almost 13 to 14 centimeters, which is again defying the regular physiology. But the anti-inflammatory effect with targeted therapy just burns away the inflammation and allows for compensated growth also. The other kid was around the same time. This was a psoriatic arthritis, it's bad foot disease, supremely bad tarsitis. And you could see the MRI showing dactylitis with florid tenosynovitis around the big toe. The enthesis part of it, the greater trochanter is lighting up nicely. And this was a limping child with an ESR of 80, 90 with SI joint and bad enthesitis of the foot. And this child was also started on etanercept. And this is the difference how the 2 doses of etanercept was enough to reverse the story. And both these children actually ended up going into long-term remission, with the second one actually having MRI resolution of the lesions. So the medicine, as far as rheumatology is concerned, is changing with every single day. There is increasingly earlier use of biologics and disease modifying agents with extremely good results. So what did we learn today? M for metaphysis, think of malignancy, rule out malignancy, diagnose acute osteomyelitis. When it becomes chronic and recurrent at multiple sites, especially mandible, clavicle, spine, long bones, think of chronic recurrent multifocal osteomyelitis. Skin plus bone combination, think of a CNO. SAPHO syndrome is a novel condition that you may not see, but if you see, you will definitely not miss. Pyrocytosis, systemic JIA, medium vessel, small vessel vasculitis. Pyropenias, SLE. I won't go into the other differentials because anytime you have low counts and the fever going on beyond, please rule out lupus. I'm not saying prove lupus. Ruling out lupus becomes very important. You will end up diagnosing many kids with lupus. Autoimmune, every time you use the word autoimmune or any hematological terms like chronic ITP, Evan syndrome, think of SLE. We've seen how early use of DMARDs can revolutionize the lives of these kids. So while it's difficult to remember all these new brands and new drugs that the companies keep coming up with, it's actually a blessing in disguise that we are discussing biologics and disease modifying drugs in a midweek post OPD busy session, because we may not be the pediatrician. I don't expect them to know all of this, but at least they know that options exist, and the onus is on the pediatrician to make a timely diagnosis and probably an early referral, if not a diagnosis, because end of the day, rheumatology is not about steroids alone, but I think we also learned how to use steroids in a bit of a sane and sensible manner, and it should give you enough of happiness to get these kids out of trouble. And then hopefully after today's talk, I have sorted out the 2 versus 10 and 30 ka complication, right? Urgent or emergency, genomic, non-genomic. Start using this word and you yourself will find an answer, and probably not find a reason to trouble me after 11 o'clock in the night. I'm more than happy to wake up 4 o'clock in the early morning. So thank you very much for a patient hearing. Happy to take questions if there are.
Thank you, sir. It was really a fabulous talk. We were literally glued to our seats wondering what the next case is going to be. We have with us Dr. Renu Borarkar ma'am, who's an intensivist at Dooth Hospital in Aurangabad. And ma'am has been very interactive in the session. Ma'am, thank you for being with us. If you could just speak a few words. Ma'am, unmute yourself, ma'am.
Good evening, team Navi Mumbai. Dr. Amok, thanks for asking me to have few words. I also congratulate Dr. Gawani sir, Dr. Shahane sir for this keeping this excellent talk by none other than the detective Bomkesh Bakshi, that is Dr. Vijay Vishwanathan sir. He has said out that rheumatology is easy in his way, but for us general pediatrician, it was a really eye opener, sir. And as sir said in his slides, it is very, very important that we should not go for a battery of rheumatological investigation as at one time, but we have to have a appraisal of clinical history, the detailed physical examination and relevant investigations as the disease evolves, as what I got it from your slide, sir. And yeah, your armory was a very surprising thing for us pediatricians, because we will not touch it. We will refer the patient to you, sir, for further diagnosis and treatment. And the targeted DMRDs and TC-DMRDs and Janus kinase inhibitors, etc., it was tongue twister, as you said, really for us. And as you said, steroid has to be used in a proper dose, and 2, 10 and 30 ka funda you have made us understand so easy, sir. Thank you so much, Dr. Vijay sir. I always see it a point to hear your talk, sir. And I had some time back sessions with our Dr. Kupchandani sir online for a 10-week session 2 years back. So I am interested in rheumatology a bit. Thank you so much for giving me the opportunity, Dr. Amok.
Thank you.
Thank you, ma'am.
Just a minute, Vijay, you can add another M to your M's of myelitis and malignancy. Don't waste time for any other radiology. Do an MRI there.
Yeah, and save some money. So that's the 4th M or the 5th M. True. I think the message is simple, that you keep a low threshold for, you will probably not see such a child, but I'm pretty sure you will see a child. Some of you will end up seeing recurrent osteomyelitis or a recurrent infection or a bad skin disease as an unusual age. And I don't think you can send the skin to a dermatologist, the bone to an orthopedician. If it's happening in the same child, it just takes an extra 30 seconds to think, is it just coincidence or there is a genetic basis? And exome sequencing, I'm pretty sure that in the next 2-3 years, the costs are going to come even down. And it's easy to just frame a skeleton in your head, and then 2 minutes of Googling or reading should probably at least take you to the chapter. So agreed, fully agreed. MRI should be done at the lowest suspicion. Yeah.
Sir, there was one question by Dr. Bhageshri ma'am in the second case which you had discussed, the sweet syndrome. So the child was very anemic, and then she just raised the query if sickle cell anemia was ruled out.
Yeah, sickle was ruled out initially, and the only issue is clinically it did not look like a sickling, because the sickle children usually are extremely sick, is what my understanding is. And this boy used to come with only one elbow, which is almost like a hemophiliac or a hemophiliac bleeding into one joint or target joint arthropathy. Once a left elbow, then the right elbow, left elbow, right elbow. So sickling was thought of and ruled out in the anemia workup. I missed it, I suppose. But then at age 4 months, the child had a hemoglobin of 4, hardly any RBCs in the blood, was always a clue. And as I said, I know Majid syndrome for the last 7 years. So when I start seeing a young child with sweet syndrome and low HB and recurrent osteomyelitis, the first thing, as rare it might be, I was probably lucky that I thought of CDA and did a bone marrow directly. And but conventional knowledge would probably dictate you ruling out the common things. But again, iron deficiency, not there in the first 6 months. So it's just a matter of thinking, and coming to me after 8 episodes of osteomyelitis with a contracture is probably not the right way of dealing with things. So yeah.
Any other questions from the audience?
Vijay, many of the times we tend to start steroid thinking that no, it is a early mass or something, but then suddenly we remember Nitin Shah sir also in back of the mind. So what is your take for keeping the threshold of bone marrow for such leukopenic patients before starting steroid?
I removed the 3 slides that I normally carry in my presentations for obvious reasons, because I think that ESR CRP correlation wala slide, I think it's drilled into our heads. I would probably do a bone marrow in a child with leukopenia, thrombocytopenia, and anemia. The chances of hitting a HLH in the marrow is higher. But the question that you are asking me is, what is HLH and what is mass? In short, does a normal bone marrow rule out macrophage activation? Answer is you can have a normal bone marrow in macrophage activation, which follows pro-inflammatory conditions. HLH follows leukemia as a protocol. It's just a nomenclature I use for understanding. H for hematology, H for HLH, H for Nitin Shah ka do H, HH, right? Whereas a macrophage activation is an angry inflammatory cell. So wherever there are macrophages, whether it's the liver, Kupffer cells, whether it's the brain, glial cells, whether it's the kidney, mesangial cells, it can happen anywhere in the body, and the bone marrow is the last to reach. So I may have a perfectly normal bone marrow, WBC count maybe 15,000, like we saw the systemic arthritis patient, only the platelets are low. So remember, if possible, you do it, but don't rely on bone marrow to treat the child. Abnormal marrow makes life easy. A normal marrow puts you back on the clinical judgment wala algorithm.
Yeah, but it has an added advantage of ruling out leukemia.
Yes, but that's again, look, if I have to pulse solumedrol, then I would probably do a bone marrow in a unknown case. But if I have a known systemic arthritis or a known SLE patient, I may not need a bone marrow. A simple ferritin coming high, fibrinogen coming low, ESR CRP discrepancy will probably, and a high ferritin obviously, will clinch you the diagnosis. But a virgin case, infection versus malignancy, please do a bone marrow.
Vijay, sometimes we, being in medical college, gets cases which are like now almost evolving to evolved case of SOJI or something like that, but UPCR and all comes normal. So somewhere it like oral medication in OPD basis hampers the UPCR value, or kidney is normal is your interpretation?
So first thing is urine PC ratio has to be done on a first or a second sample because orthostatic proteinuria comes in your way. Second rule is someone who's taking a lot of NSAIDs, which is why at the primary pediatric practice level, I would refrain from using naproxen-like drug in the first week of illness at least. Mefenamic acid, very, very SOS basis. Do not make the mistake of writing a TDS Meftal-P only because the patient is making a QID phone call to you. Advise them adequately that you will use mefenamic acid very, very sparingly, because I have seen 2-3 kids land up with interstitial nephritis with 3 doses of Meftal-P, which is idiosyncrasy. It's not iatrogenic always. It is idiosyncrasy. You write it 3 times, the mother thinks 4 to 6 hourly, and the child gets fed 8 times and happens to be the unlucky one. So NSAIDs can cause proteinuria by virtue of the nephritis component. You will be lucky if you don't see hematuria. But then why am I sending a urine PC ratio first? That is the question. Not in all fevers do I want a PC ratio. In a PUO, if I don't want to give steroids, then I use the PC ratio as a thing. If it comes normal, I can give naproxen. If the PC ratio is deranged, then I may intensify my rheumatology workup because this child needs steroids at some point of time. So that's the usual way you sort it out.
No, the scene is if he takes oral steroids somewhere outside, then UPCR comes normal.
Yeah, it will be normal. That's the problem. And then the issue is what steroid has he taken? If he's taken dexamethasone, which is a supreme long acting, because many often I've seen POs getting referred to me, 14 days of continuous fever and 5 days the child is totally normal. Some magic happens, and from interior Maharashtra, by the time they come to Mumbai, the child is happy. And मुंबईत आल्यानंतर परत fever starts, and हा रस्त्यामध्ये त्रास नाही व्हायला पाहिजे म्हणून एक emergency injection दिला जातो, which often ends up being a Dexa or something like that. But the idea is things will evolve at some point of time. As pediatricians, we should not give steroids blindly, which we don't. Unfortunately, if someone of your colleagues gives the steroids and refers, or the patient comes to you, then you are to fly blind. So, and then when you see the evolution, you will see resolution equally fast. So that's the way.
Can you tell evolution of the referrals also in a typical case of rheumat from a general practitioner to general pediatrician to medical college, and then rheumatology, and then Nitin Shah versus Pankaj Deshpande versus Amol? So when we should do kidney biopsy, what I mean?
That is a very controversial question. I think the problem doesn't end with the pediatrician being a traffic policeman. Pediatrician should probably also apply his mind, which is difficult with the volume abundance that you guys cater to. It becomes difficult to think, and thinking after 10 p.m. or 11 p.m. becomes even more a problem. But just spend 5 minutes when you wake up in the morning thinking about what are the problem cases that I have, and start making a list of the problem issues, like we did for that SAPHO syndrome, synovitis, arthritis. The patient is showing you, you are not seeing, and that comes with. So I only do rheumatology. The day I see 10 patients a day, it's a very hectic day for me. 5 patients is average. You people see 100 OPD or फिर भी कम नहीं होता. That becomes, and then which fever will have a convulsion, which will change pediatricians, which will get hospitalized, which will sue me medico-legally, lot of issues. So I think I am biased to being a rheumatologist. Send all of them to me is probably the answer I will give you. I will refer to a nephrologist or a cardiologist because the least I can do is spend time with the family. And from a problem list of 5, I can say 1, 2, 3 kya hai, 4th or 5th kya hai. 6 to 10 you will delete, 4th, 5th you will postpone. Between 1, 2 and 3 आज का दिन क्या important है वो आज करो, कल नेफ्रो है, परसों कार्डियो है, depending on whether the cardio is in Iraq or wherever he is. So we can do that also. Sorry for the long answer.
So you're being very humble.
I always become humble
If
after
that
11
was so
p.m.
easy.
After 11 p.m. I become very humble and nice because you're making me stay awake 3 hours after my REM sleep. So, but it's not as difficult as you make it out to be. The idea is it's the same thing. If you ask me what's the latest TB guidelines, I wouldn't be knowing about it. You ask me what is GINA guidelines. Oh, Jitendra, before even send me GINA, to uska aa jayega guideline aisa. So each of us, I think, have a dedicated job to do. If you do your job correctly, he does his job correctly, I do my job correctly, the kid gets benefited. And it's just a matter of slowing down a pace a bit. Think, patient shows you everything, stop looking, start seeing. ESR, CRP, see the pattern, how he's behaving. Good old pediatric training helps you. Sick child, non-toxic child, once a day fever, thrice fever. And little bit of sprinkling of new things will keep on coming here and there. So just do your job with sincerity and honesty. Life becomes very easy. Yes.
Praveen Modi sir, you have a question, sir? Any other questions from the audience? So I think
हमेशा का क्वेश्चन है वो खुफिया नंबर कौन सा है सेकंड नंबर?
खुफिया नंबर नहीं है मतलब वो नवी मुंबई का पीडियाट्रिशियन नहीं है. प्रॉब्लम ये है कि अभी खुफिया नंबर भी पेशेंट इतना पीडियाट्रिशियन has become so busy that my खुफिया number is getting passed over to the patients. And one of the pediatrician culprit is there in the audience today also. I am going to see that patient in a day's time, but yeah, it's not that I don't want to talk to patients or pediatricians, though it's the reverse is a problem. The pediatrician can't spend more than 10 minutes maximum talking to me. That is also if I catch them in the afternoon. And after 10 o'clock, it becomes really difficult in the evening to catch me. People like Mangai will stay on and on and on till 3, 4, 5 o'clock in the mornings when I am half dead. I say, I wish her good morning. She wishes me good night. Right. So bottom line rule I follow is medical decisions regarding therapy should not be made in the second half of the day. If it is in your hands, especially the chronic ones, complicated ones, 2 ki 10 ki 30, probably the answer you yourself will be able to find if you are in a sane frame of mind. रात को 11 बजे फोन आया रेसिडेंट का कि 2 से दूं कि 10 से दूं, you obviously are fatigued. You know that ये बच्चा ठीक होने वाला है. That's how I think. Don't think 2 की 10 की 30. Think कि 30 से ये ठीक होने वाला है या 10 से ठीक होगा, ये बच्चा ठीक तो हो रहा है. That will just give you that extra 5 or 10 breaths to breathe. And then you see your clock or your watch. Oh, it's 11 p.m. No, Vijay is not available, or he may not be the right person. He will be sleepy. Let me decide. कल सुबह विजय को क्या करेगा? 2 का 10 करेगा या 10 का 30 करेगा. 30 का 2 तो नहीं होने वाला है, हो सकता है, right? But then most of the times you are as clever as I am, and it's just a matter of खुफिया number रखो अपने पास, but don't give it to patients just because you want maximum productivity from me. Such a long answer is only so that you don't give my खुफिया number to patients. But feel free to call me anytime, and best way to reach is WhatsApp still. Send me a WhatsApp. If you don't get a call or a reply back in half an hour, you assume that there is something wrong. This is what I tell the parents. WhatsApp karo, jawab nahi aaya, matlab your question is not worth answering. I don't say the same reason to the pediatrician. It's just that I'm busy somewhere. But I will usually I respond.
But it means same.
Huh?
But it means same.
Nahi, I might get stuck occasionally with patients, but WhatsApp, I think my record is not that bad, the way you make it out to be. Most of you make, or many of you, not most of you. Most of you don't complain these days. So
विजय विश्वनाथन को 3 सर होने चाहिए तो अच्छा रहता।
3
सर होने चाहिए, 3 सर, 3 हेड।
उससे क्या होएगा? एक खारघर की तरफ देखेगा, एक 10 रुपए के कॉइन जैसा। वो तीनों सर एक ही है ना, वो एसओजेआई जैसा ही है, दोनों शोले का कॉइन जैसा ही है। कहीं भी जाओ, विजय का 1 सर रहेगा तो भी या 3 सर रहेगा तो भी 10 बजे सो जाता है वो। दैट इज द प्रॉब्लम। So better that one head only sleeps so that one head wakes up fresh in the morning. Anytime after 5 is fine. So the latest example I give is Jackie Shroff in Border. I am like Jackie Shroff in Border. I can't function after sunset. Wait for the first sun rays to come out and then you will see a different Vijay in the mornings. That's what happens, no, in the movie. I think
whole night we were awake and credit goes to Vijay in the morning.
That's fine. Patient wakes up, goes home, thanks you guys equally, no? IT returns I will send you just to see which one is better.
Yeah.
Perfect.
Okay. Thank you so much, sir. Wonderful discussion, wonderful talk. I would now like to call Dr. Mangai to give the official vote of thanks.
Thank you, Amok. I think I'll make this a little short because Dr. Vijay has already told us many times that it is well past his sleeping time. I should really say that I really wait eagerly to hear him, and I'm really happy that this is a recorded session because I keep hearing his lectures again, because half of the times, the first time when I hear it, I can only make some sense out of it. So to make complete sense out of his lectures, I really need to hear 2-3 times. So I'm really happy that this is a online CME and not a physical session, because we have this recorded for all of us to refer. His talks make me a little nervous, but yes, it does sensitize all of us to what's new and what we should really look out for. It's like the saying that goes, the eyes only see what the mind knows or is ready to comprehend. So after years of drilling, I think we are now comprehending the CRPs and ESRs, and we are sending it together. And this time with all this high fevers, persistent fevers, recurrent fevers coming, I'm so happy to do the CBC, the CRP and ESR and tell the parents, okay, it's still not time to phone a friend or WhatsApp a friend. I can still handle this case. So I think, thank you, sir, for in such a short duration, you took us today in this new topic of bones, chills and pills. I was wondering what you would talk on, bones, chills and pills. And you took us through all these new entity of chronic non-bacterial osteomyelitis, as well as touching and telling us something more about sweet syndrome, MAS, HLH, the juvenile arthritis, also sensitizing us to the newer therapies, not steroids, but the newer therapies, the anti-cytokine therapies, the JAK inhibitors. There's so many new things which has come, which is targeted therapies to hit these diseases and give a better life and better treatment for these children. We will definitely remember your simple take-home messages in chart in OPD. And I should say we are good learners. So we will try and inculcate all that you have taught. Also, the most important message, when to call you and when to message you, so that we know that whatever patient we face, we always have help, and we can always reach out to you. Thank you so much for your lecture today. Thank you, Dr. Vijay, sir, for being with us here.
Thank you.
I would also, thank you, sir. I would like to thank Dr. Amog for moderating today's session in such a nice manner and taking everything so smoothly. I would like to thank Dr. Jitendra Gavani, sir, Dr. Satish Sahane, and the entire NMAP team for getting us all these discussions, new topics, and keeping our mind thinking and making us better practitioners. Thank you, Team Navi Mumbai IAP. I would like to thank SIPLA for being the academic grant and being a support today. I would like to thank all the delegates to be with us despite the busy OPD and this late hour talk. to join us. So with this renewed thoughts and renewed thinking, let's all begin new OPDs and new ways of treating these children when we face them tomorrow. Suspect them, treat them. If not, then call Dr. Vijay Vishwanathan. Thank you, sir. Thank you, everyone. Good night.
Bye. Thank you. Thank you.
Bye.
Thank you.
Thank you.